You try to say brown, and sometimes it's green, depending on which company you use. Those are the largest ports, so you use those for blood draws. So if you're going to use, if you're going to do a blood draw on a patient that needs lab work, and they're not sticking them anymore, you're getting them through their central line, you do have to turn off your TPN for a few minutes just so you can draw the blood. So what you do is, what I do if I'm going to do that to a patient, I go in the room the morning, identify who you are, and make sure the labels I got for this person. I turn my TPN on pause. And while I'm getting my stuff together, that's enough time, because you have to let it stop running for at least 2 minutes. So by the time you've done all that, you got your syringes together, you're able to draw your blood and start it back up again. But you want to make sure, this is the thing you have to do, draw 5 cc's of blood, that's waste, and then draw your specimen. And then you flush it, and then you start your TPN again. Okay, so you're always going to waste 5 cc's of blood out of a central line. Because you want to make sure there's no, that if there's anything there, because those numbers could hemolyze the blood for one thing, because there's a lot of glucose there. But the other thing is that you want to get a true value for what the person's lab work is doing. So 5 cc's to waste. Then you're going to draw your blood product, your blood for whatever you need for your syringes, flush with saline, and then you start your TPN back. But definitely you're going to see lab work every day for about 7 to 10 days until we get this person straight on what their values are in their electrolytes, but also you're going to we change how much insulin we're putting in there based on what they're doing and how they're responding to it. But they will go on insulin coverage for that reason, because this is 50% glucose that you're giving the patient. So you will see some changes that kind of go along with that. We monitor the patient for signs and symptoms of infection, because that's the biggest thing you see after patients have central lines inserted. Unfortunately, it tends to be one of those things. And the big thing, of course, is that as soon as you can get it out, you want to get it out. Because that's that whole thing about source control. In that sepsis video, remember? You want to get rid of anything that you can that can cause infections in a patient, or that can be a vector for causing problems for a patient, and central lines are a big culprit. Central lines, Foley's, those types of things. So source control means I want to get rid of those things that can cause a problem for the patient. So if they have a drain, as soon as I can get it out, I want it out. If they have an IV or central line, as soon as I can get it out, I want it out. If I have a Foley catheter, as soon as I can get it out, I want to do that. So that's talking about source control. Minimizing the exposure of a patient to getting sepsis in the first place. All right. But TPN is something that can be used for, it can be continuous. It can also be cyclical, meaning that you can have a patient that if you want somebody to try to eat on their own, just like you do with tube feedings, you may do it for certain parts of the day. And they usually do PPN for that one, partial parenteral nutrition. So that person, dextrose solution is not as high, so usually you see 10% on that. But still you have to, it's not quite as much glucose, but you can still have issues with patients with their blood sugar. Now I will tell you, if you're getting ready to take a patient off TPN, what you generally see is that the doctor's going to start decreasing the infusion rate. They usually cut it by 1/3 at the beginning, and then they cut it down to half, and then they run it at KBO for a period of time. Or you may see a doctor that says, say if it was running at 100 an hour, the next time I'm going to run it at 66, and then the next few hours I'm going to run it at 50. You have to do it as a gradual thing, so your body can adjust to it. Because it's usually for 8 to 12 hours, depending on what the physician writes. If you're at the end of your bag, because they're not going to create another one for you because you're at the end of it, but you don't have enough to continue on the rest of the time that the doctor says to do that, you can hang D10 and do it. Okay, so you have to have some percent of dextrose going into the patient, and that will help you wean them off so that they're not hypoglycemic. I skipped all over pancreatic cancer, didn't I? Ooh, Lord. So pancreatic cancer, I just remember I didn't talk about a cancer. Unfortunately, it has a high mortality rate. A lot of times when we see patients who have pancreatic cancer, there is well advanced when we find it. Or we have a patient who presents with jaundice with nothing else going along with it, because it usually doesn't have symptoms, meaning that the patient's not having pain. Those types of things, talk about patients have pancreatic cancer. They all of a sudden turn yellow. That's the unfortunate thing. But in some regards, it's a good thing if that is where the tumor starts in the biliary tree, is because it causes that obstruction is found earlier. But most of the patients don't present that way. So sometimes what you'll see in the patient, they may have signs and symptoms of, they may have abdominal pain, I should say, some slight cramping or discomfort in the right upper quadrant that the patients complain about. So a lot of times people put it off to gallbladder disease and they don't get a lot of other evaluation for it. Until later, patients end up saying, hey, something else is going on with me. I need to figure out what's happening. And a lot of times they will present with obstructive jaundice. So that's why they're yellow when they come see you. So they have to investigate whether or not it's a gallstone, because gallstones can produce jaundice that way. But if they find pancreatic cancer, much more problematic, because this cancer usually is advanced by the time it's found. What ends up happening is you have a patient who goes for what we call an ERCP, or endoscopic retrograde cholangiocarcinoma. I can't even say the whole thing. But they're going in, and with this one, they can actually look at the head of the pancreas. They can look at the gallbladder and bile ducts at the same time. So they go in there and they look and see if there's something there. They look at the top part of duodenum, so they're actually able to visualize all these structures to see whether or not this patient has cancer. And then, of course, because it's an endoscopic procedure, they can actually do a biopsy. So they can definitively tell you whether or not this patient has cancer. If we find that the patient has cancer, if there's a lot of weight loss, I may send the patient home to get better before I do surgery. And that's mainly because we know that they do better in healing, better long run type of thing. And I've had patients on either side that's what the doctor does. I'm going to send you out of here, put you on tube feeding, because the patient didn't go home on TP, and they actually put in a, he had a Dopphoff tube and he went home. And was going to be home for 3 weeks before he came back to have the surgery. Because cancer's already there. It's not a lot of difference going to change in what's happening with the patient at that point. So he goes home and he comes back for his surgery. He does well. He ends up going, and because his cancer was early, they expected him to make a good recovery. That's not the usual thing you see with pancreatic cancer. It has a high mortality rate, and most people, when they have, especially if they have mets at the time of diagnosis, are usually dead within a year. That's one of those life-limiting illness kind of hospice consults when you see patients who have pancreatic cancer. But we can do surgeries for it. Whipple procedure is the surgery that goes in and reanastomoses everything in the GI tract. The Whipple procedure, when it first started, I was probably a nurse maybe 5-6 years when we started seeing patients at our hospital. It was done at other places. It was done at Tampa General, because the doctors there were the ones that started first doing it in our area. You would send it, pretty much any patient that went to have this surgery, you may get 1 or 2 back, because the mortality rate was so high associated with the surgery. Much better techniques now, so patients are doing a lot better. Surgery lasted anywhere from 6 to 12 hours, because essentially they had to resect everything in the GI tract and put it back together. So that's why patients didn't do well, because I was talking about, every time I saw that procedure, I was like, I wonder if this patient's going to come back. I truly, way back then, you may have 2 people out of 10 that will come back to the floor. Other than that, they die, or they end up on ventilators and all that kind of stuff, and end up going back to going to some ALF or something like that. It was just horrendous. But now we have better techniques. Patients' surgeries are lasting a lot shorter. Patients are doing a lot better post-op. So a lot of stuff has changed as far as technique, which is good. So we have people that survive. But the procedure itself is very involved, and they like I said, reanastomose everything. The pancreas, the bile ducts, the intestines, the stomach, everything is redone, and they take out the cancer that is there. Now, depending on what the cell type is, you still have patients who will, get radiation or get chemotherapy. A lot of people, they just open and close them because the cancer is so extensive. So they just do palliative care about what's happening with the patient. And even when you have patients who we find the cancer early, generally in this day and age, when you talk about patients who have cancer, there is nobody that's just going to have surgery. They're going to either do chemo or radiation because they want to make sure they got everything with the patient. Yes, I got the cancer. I saw that I got the tumor. I don't see any other seeding there, but you're always in the back of your mind wondering if one cell got away, should I have done treatment? So now doctors opt to either do chemo or radiation, one or the other, that the patient's going to have after the fact. But of course, because most of these patients do not have that option, it really is one of those things that you have to do a lot of support, psychosocial stuff, because pancreatic cancer has such a high mortality rate. And then you'll see people, you know, that who have had surgery, had treatment, and even though they do all those things, they still don't live the 5 years that you talk about as a survivor of pancreatic cancer. So it's one of those, definitely on the, in most of the cancers in the GI side, when you talk about gastric, pancreatic, esophageal, those have a high mortality rate with them. Colon cancer does, but it's not as bad as these, and then mainly because of the whole screening thing. We get screened at age 50, or like me, you carry around your prescription for a couple more years until your doctor tells you don't come back until you get it done. But at least there's a screening process that goes with that. With these others, it's only because we just happen to find it because you have these complaints. And so that's what one of the big issues is. If you have a patient that does have, there are clinical trials, a lot of them for patients who have pancreatic cancer, because they're trying to figure out what is the mix that's going to help patients have better outcomes. Because unfortunately, even though we get new stuff with it, we're not finding that we're still having people live 15, 20 years after they have some type of cancer scare with pancreatic cancer. So unfortunately, that's one of the things that we see. All right, y'all want to take a break? And then we'll come back and go back over our hematology stuff again. And then I have to actually, sometime today, because I went to take care of my niece this weekend and cause her trouble in instruction, and put up the things for, there's several, because I don't think you can see them, because Will asked me a question about, there are some hematology ones, but I don't, if they're not open to you, that's why you can't see them. So I have to put those in today.
Are you talking about involved?
Yeah.
Oh. Oh no, that's what she said. It's here that we can't see this. For the involved. I'm gonna go for it.